as far as understanding the physiology behind the heart. Because if you don't understand that, you're going to struggle with the disease process. So this is something that you really need to get a handle on as we progress, through the different diagnosis. Okay? So, again, when you're looking at the myocardium, guys, it is truly one of the most unique muscles in the body. Why? Because it can initiate its own impulse, transmit an impulse, and respond to that impulse with what we refer to as a mechanical contraction. Now, for those of you who need your brains a little refreshed, the electrical conduction system consists of, what is that? Okay, so atrial, AV, Purkinje, okay. How does all this work? The electrical conduction sends, this is considered the pacemaker of the heart, 60 to 100, 40 to 60, 20 to 40, not very effective. But this all occurs prior to the actual contraction. If you look at what makes this occur, it is simply, it's really an exchange of ions. So if you look at the big ones, potassium, magnesium, sodium, and calcium. If you remember, potassium is your intracellular ion, sodium your extracellular. This all consists part of what is called the electrical potential, cardiac electric potential. If you were to put leads on a patient, you would actually see the electrical conduction system. Most of you see it as the P, Q, R, S, T. Okay? This is called the isoelectric line. Okay? Now, what causes this contraction? Well, the electrical conduction system, which occurs prior to the contraction, this causes an exchange in these ions. So when potassium and mag move out of the cell and sodium and calcium start to move in, that's when you see depolarization. This is depolarization of the atrium, okay? So this is the heart contracting. That is called depolarization. It occurs because of this exchange of ions. Are y'all with me out there? Because I'm taking you to a different level.
I want to need more coffee. You're going to have to slow down.
Okay. So everybody, I think everybody's got this.
Yeah. AV nodes and Purkinje is, what's the numbers for the...
Okay, 60 to 100, yep. Right, theoretically. 40 to 60. 20 to 40. Now remember, this mechanism does everything in its power to not fail. So if this is not firing, this one kicks in. Okay? And this is normal, guys. This is why you have got to have a foundation in normal, or you're going to struggle with the rest of this. Especially in 213, when we get to STEMI and non-STEMI and cardiogenic shock. So, this is the basic normal mechanism. Now, what causes this mechanical contraction? This is electrical, but it is the actual exchange of ions. Potassium, mag, sodium, and calcium are your biggies that affect the myocardium. So when your potassium level is low, your heart doesn't like it very well. When your calcium is low, your heart doesn't Okay? So what happens to make a theory that is very difficult to understand, very simplistic, what happens is these start to move out and your calcium and calcium and sodium move in. When that exchange occurs, then the heart pumps, it contracts. That's called depolarization. Atria and ventricles out there. Y'all are looking at me like, holy crap. Here we go. Now, when the heart contracts, it has to feel for the next beat, right? So, what happens at the cellular level is potassium and mag start to move back into the cell, sodium and calcium move back out, and that is called repolarization. So you would think of this as contraction and filling. That's what happens. You didn't know before, you do now. This is what Miss Bowie says the heart's depolarizing. Now you understand. The exchange of ions at the cellular level comes immediately after the electrical conduction. This comes first, and this responds. Does that make any sense? Okay. So, a very, very unique muscle. And like I said, this will fire until it can't fire anymore. Okay, you can even have what is called the electrical conduction system is still working and the heart's not pumping. That's a lethal dysrhythmia called pulseless electrical activity. So, what you need to know from a general standpoint is the mechanism of what is happening within the myocardium. Okay? If you don't, it's going to be meaningless when we get to EKGs and all that good stuff. Okay? Now, the actual myocardium is affected by other factors. In particular, volume. When you look at the pressures within the myocardium, which are generated as blood flows through the chambers, closure of the valves, mitral tricuspid closure initiates what? Systole, diastole. Guys, you've got, come on. Systole, diastole. Systole. Closure of the mitral tricuspid valves initiates systole. Closure of the aortic pulmonic valves initiates diastole. Okay. Closure of the mitral tricuspid valves initiates systole. Closure of the aortic pulmonic valves initiates diastole. Got it? Okay. We'll go over it again. You may say, we're not rushing this. This is the foundation that will carry you. Okay? If you don't understand the physiology behind the myocardium, you will struggle. I've seen it 100 times. Okay, so the actual contraction is affected by what is called that initial stretch of the ventricles. Okay, it's actually referred to as the initial, that stretch, those myofibril stretching of the ventricle. So imagine the blood going in, right? It's going into the ventricles. What affects that? Critical factors, volume, the atrial kick, meaning the atria actually contract, and the condition of the valves. That helps determine that stretch on those ventricles. Okay, a lot of this goes back to what was called, or what is still called, probably Starling's Law. That law basically said that the heart, whatever the amount of blood that it receives, and you get that stretch, it's going to pump that blood out. Now that's a normal heart. This is also referred to as the rubber band theory. Is anybody have a rubber band? No. Think of a rubber band and think of the heart. You pull the rubber band, it goes back to normal. You pull it again, it goes back. Now think of a rubber band that's been pulled so much till you pull it and this is all it does. Well, that's what can happen to the heart when disease processes set in. So the amount of blood that it's pumping, it's not able to do that because it's overstretched. So when the myocardium is overstretched, it doesn't go back to where it was. It can only do this. Does that make sense? Why is that important? That's why you will understand why one patient can be on a beta blocker, a Pril, thiazide diuretic, and a calcium channel blocker. Because the condition of that myocardium is like the stretched rubber band. Or think about that underwear that you have worn forever. And no matter what, you are not going to get rid of that underwear. And the elastic in that underwear is just not there. And it's not going back to what it used to be. Okay? It's done. So those principles need to be applied to the myocardium and the actual contraction that it produces. Now, not only blood going in, but the heart has to pump against, has to make it go out. Well, that is called afterload. Now, you have resistance in your systemic vessels. You have resistance in your pulmonary vasculature. So, let's say you have chronic, uncontrolled hypertension. What happens to these vessels? They get tight. Well, guess what has to pump against those tight vessels? And it will pump until it can pump no more. But what happens, guys, is the pressures in the chambers change. Because they have to work so hard to get that blood out. Okay? Same applies with the right side of the heart. It has to pump against the pulmonary vasculature. So if you smoke for 40 years, your right ventricle is having to work harder and harder and harder to get that blood out. And again, you can't look at one distinct chamber. What affects one chamber will affect the others. Okay? Because it contracts simultaneously. Okay? So these are determinants of your actual mechanical contraction. Why is that so important? Because it boils down to the almighty perfusion, cardiac output. A lot of students will say, tell me what cardiac output is. And they'll say heart rate times stroke volume. What does that mean? How much is being put out? Liters per minute. Liters per minute. Normal is about 4 to 6, 4 to 8. So theoretically, we want a heart rate of 60 to 100, and you want a volume. This is the amount of blood per beat, is the stroke volume. And that, of course, is determined by this. So, in a normal heart, you can have great perfusion. But in a diseased heart, or a myocardium where one of the ventricles is now infarcted, that tissue is dead, then this becomes an issue. And again, you will learn why you're on a beta blocker, calcium channel blocker, a diuretic, and da-da-da, because you are trying to then protect that myocardium. Okay? So, by understanding this, when I start talking about the vessels and these pieces of plaque in those vessels, then you should be able to tell me what is happening here and what's going to happen here. And how is that going to affect this? So by understanding this, it helps you to understand the disease processes, okay? I'll go over the PowerPoints in just a minute. In your coronary arteries, you have the right coronary artery. That's your big supplier of the right side of the heart. You have your left main artery. This is referred to as the widowmaker. A big occlusion in the left main, you may leave somebody alone if you're not diagnosed and treated. Your left anterior descending artery supplying your left side of the heart, and your left circumflex. Those are some of your big arteries supplying the myocardium. Okay? Questions? Comments? Okay, where I'll show you the slides. The slides will give my visual people even some more things to look at. Diastole, closure of the aortic pulmonic valves. Okay? Again, the blood flow the closing of the valves, all of that is what's generating these pressures, okay? Now, again, this is just one of those cute little mnemonic things that may help some people, but again, the big thing is you need to understand what the closure of the valves really means as far as a myocardium. Okay, now here's a good picture of your different pressures within the heart. You can see the right side of the heart has low pressures. The left side is the one that has the higher pressures, okay? So, when you look at this, a lot of this, let's say, give me an example. Okay, let's say that you had an infarct and this part, say right here, is now dead tissue, okay? So, this being a low pressure system, what's going to happen to preload on that side?
That part's not going to stretch.
It's not going to feel.
It's not going to stretch, right? If this section right here is dead tissue, we call that akinetic. Okay, that's dead tissue. Is the preload going to increase or decrease?
Decrease.
Remember what I said, the heart will never stop pumping.
So it increases.
It's going to work harder. So it's got to have, preload's going to go up. So it's going to require more volume. It's going to want a stronger atrial kick. And the valves better be working. Or what will actually happen? What will the heart rate do? Because, think about it, guys. Come on, visualize with me. It's working harder. That right ventricle's having to work harder now because it's got dead tissue here, right? It's akinetic. It doesn't move. So the rest of the ventricle's got to try and pump that blood. So the pressures are going to increase, preload's going to increase, and you better get some volume in this patient. Because why? What will the heart rate do to respond now to that decrease in perfusion? Autonomic nervous system says increase. Increase that heart rate. Give me blood. So heart rate will go up. Well, if you don't restore volume, what's happening to your blood pressure? And your patient's going down. Okay? So this is why you're looking at these different pressures within the heart. Okay? Again, if this side of the heart is having to pump against that vasculature that's very tight, it's got to work harder. If you've been smoking for 40 years, that vasculature of the pulmonary system is tight, this has got to work harder. Preload will go up, and you got to treat it, or your patient's going to have issues. Here's a good picture of your coronary vessels. Okay? Now this is right here, this baby. You get a big piece of plaque right here. Like I said, we call that the widowmaker. Because you're going to shut pretty much blood supply down to the left side of the myocardium. Because it's feeding the circumflex and the LAD. Okay? Now this I went over, it's the electrical conduction system, occurs immediately before the mechanical contraction. This is, again, about the almighty perfusion, which is what the heart is meant to do. Again, I divided this up. Heart rate, your autonomic nervous system, again, changes in your initial stretch to the ventricle, your resistance is going to affect your cardiac output. This is just going over preload again. Again, think of that stretch. It's determined by volume. So, if you have a patient with, let's say they're in the hospital for abdominal surgery, and they have a history of congestive heart failure, and the GI doc says, I want those fluids running at 150 milliliters per hour. The gut needs those fluids. What's going to happen? What's going to happen, guys? It's going to become overloaded. And what happens? The heart's going to have to work harder and harder, right? And then you're going to get all this backup in the plumbing. And before you know it, you have a patient who can't breathe. Right? Because the perfusion is failing. So that's an example. Again, Starling's law, resistance or impedance that the heart must pump against. This is one of these cute little pictures that may sometimes help students to get a better visual of what's going on. Again, you can see the volume, and it's got the little pipe vice thing there for resistance. So, as a nurse, understanding the physiology behind the myocardium helps you to assess your patient in regards to perfusion. Okay? So when you are assessing a patient, you should always get in the habit of trying to do an apical pulse, because you are going to learn about all those dysrhythmias or irregular heartbeats that we hear. You're going to actually learn those. What happens when preload increases? Okay, well, think about it. Everything's the plumbing gets backed up, right? So perfusion's impaired, the resistance gets tighter, the heart rate goes up. All of those are compensatory, but is it actually helping perfusion? No, it's not. So when this increases, this is what you could see in your patient. So if you'll think of the right side of the heart pumps against the pulmonary vasculature. Okay? So that plumbing gets backed up, right? So we've got now the edema, JVD, right? Because it goes from RVRA, superior, inferior vena cava, right, coming in. So all that gets backed up from here, and like I said, the plumbing gets stopped up. So that's why you see your edema, your JVD. Let's say you're hypovolemic. You don't have fluid volume. What are you going to see in your patients? Well, most of you know what you're going to see in fluid volume deficit. But still, the heart cannot work effectively. This would be like your post-op patient. Your post-op patient requiring volume. Without adequate volume, you see changes in your heart rate and blood pressure. And for a lot of students, I divided it up because it's easier for them to think of the plumbing backing up on this side and the plumbing backing up on this side. So that's why I've separated it. Okay, so the plumbing's backing up on the left side. You got to think about the blood flow. Right? So what are you going to see in your patient? Okay, pulmonary, what? Possibly, but crackles, coughing. Okay? Think of that enlarged left ventricle. Okay? And it's not pumping effectively. Remember the pulmonary artery going into the LA to the LV. So all that plumbing gets backed up. And you're going to see the coughing, the dyspnea, shortness of breath. Okay? Okay, the contractility, again, is the heartbeat itself. That's impacted by your heart rate and stroke volume. Now, this is your resistance. So, if you have a tight resistance, what are you going to see in the body? Right. You're not getting that perfusion, okay? And I've also put in slides again about the electrical conduction system. The heart is, the rate is controlled by the autonomic nervous system. You actually have baroreceptors in the carotid and aortic arch that respond to volume changes and changes by the ANS. These I just threw out are terms that in particular you will see in your drug books. This is the word for rate. This is conductivity. A lot of you may have seen this one. Digoxin is a positive inotropic drug. It actually enhances the ability of the heart to contract. So those are just some terms that you would probably see in your drug books. This is something, guys, that if you will think about when you're thinking about the electrical conduction system, you know, the heart is truly like the electric eel in that when it moves, it generates impulses. It's just with the heart, it's the exchange of the ions that causes the depolarization and repolarization, which is contraction and filling. This is the actual theoretical action potential. Usually students understand my little circles a little better. This does occur in set phases. Okay, but that's pretty much my little circles over here to give you an idea of what is actually happening within the myocardial cells. That I went over. Here's your SA node, your AV, and your Purkinje. Now this is good. Again, look at the SA node. Now let's say you had an infarct on the right side of the heart. what do you see on this side? SAAV. So if you have an infarct on the right side of the heart, are you going to have dysrhythmia problems? Oh, yes, you are. Oh, yes, you are. They're notorious for bradycardias or slow rhythms. So SAAV, your bundle, you got your left and right bundle and your Purkinje fibers. All of that part of the electrical conduction. Okay, you need a break, and do we need to... A lot of this, again, it goes together, but this is the amount of blood ejected with every beat. The autonomic nervous system controls the rate. Okay? So if you think of this is your almighty perfusion. It's a muscle. Okay? It's unique in that it has its own electrical conduction system, like the eel. Okay? And I went through that. The exchange of ions, so the electrical conduction system fires, and then the exchange of ions is what actually produces the mechanical contraction. Okay, in a nutshell. Now, other factors that affect that are preload, that initial stretch on the ventricles. So, volume. The ability of the atria to give forceful contractions, and of course the condition of the valves. Okay? Afterload, if you'll think of that resistance. Okay? So like here, if you've got, here's your systemic resistance. Okay? So if you've got long-standing hypertension, then that resistance tightens. So the heart has to work harder to pump blood to where it needs to pump blood. And the harder the heart has to work to pump blood in our patients, the cycle goes downhill. Okay? So if you think of this patient with congestive heart failure, and they're not, let's say they didn't take their Lasix for 3 days. So with that extra volume, the heart's having to work harder. And the body, the kidneys, the brain is saying, I need blood. I need blood, people. Give me blood. So the heart works harder. It increases its oxygen demand, but because that stretch on those ventricles is not good, okay, what happens, guys, is when the myocardium is diseased, the ventricles don't shrink. They actually enlarge. And when they enlarge, that's your underwear with no elastic. It doesn't go back to what it's supposed to. So as it enlarges, the amount of blood pumping out is less. The amount of blood coming back is less. And the cycle continues. And the patient will crump if we don't get rid of that volume and lower that heart rate. Right? Okay. So, now you're just seeing, okay? So, different factors affect cardiac output. And the body is unique. It always tries to protect itself. So, when the body is not getting enough blood flow, again, this thing right here does not tolerate it. It will demand. I always call the brain Big Daddy because Big Daddy does not tolerate lack of blood. Okay? it will send out a message to pump. Pump hard. Pump fast. I want blood. But we know in that damaged heart, that cycle is going on. Less blood going out, less coming back. So the plumbing starts backing up even more, right? Edema, so all I've got is this dang fluid, and then the kidneys are sitting there going, I'm not getting blood. So the kidneys, this is to help you understand your ACE inhibitors and your ARBs. When the kidneys aren't getting the blood flow, the kidneys release renin, angiotensin, aldosterone. And when you release angiotensin, that tells the body, tighten. The main organs are saying, I don't care about feet. I don't care about the legs. I don't care about the arms. I want that blood. Aldosterone, you're going to retain more sodium and more water. So that is how a patient with congestive heart failure doesn't take their Lasix every day. And the plumbing backs up, and the heart works harder and harder, and the O2 demand rises, and the body says, I'm not getting blood. I don't like it. This will cause blood. This thing right here will cause your pressure, your systolic pressure to go zoom, because it demands it. Now the kidneys, like I said, they're going to release renin, angiotensin, aldosterone. And this poor thing is going to keep pumping and pumping until it can't pump no more. It's going to keep firing and firing. That is the need that our bodies have for perfusion. Something that we take for granted. Alert, oriented, pulses palpable, skin warm and dry. What do you think is happening to that heart as it tries to work harder and harder? Visualize, what does that patient look like? I've already told you, heart rate's going up, blood pressure's going down. What's happening to these extremities? Cold, clammy. Because the afterload is so, that resistance is so tight now. Because the body says, blood, I want it. Don't care if you lose your feet. Doesn't matter to me. Cool, clammy. The body, that is the body's compensatory mechanism to live. Okay? So, if you'll think of it that way and just really think about where the blood flow is going, you're going to have no problem understanding heart failure, coronary artery disease. You'll get it. And you're going to understand why is a beta blocker so important. Why is that ACE inhibitor so important? Why? Why is it so important for these patients? Okay? All right, what questions? Do you think if you went home and read chapter 35 and just really focused hard on this, you could draw your own picture and it would make sense to you? This is the physiology. This is not, let's listen to S1, S2, which I know. I asked Renee. She said you guys didn't have much as far as the true physiology of the myocardium. Okay? So let's look at this. And in particular, into the pulmonary system. So as a nurse, I kind of want to draw this. Okay, so as a nurse, we're going to start looking at basically who's at risk for decreased cardiac output. Okay, so that's always our first question. Who's at risk? These erasers don't work very well. Okay, so who's at risk? Well, thank you. Who can tell me? First of all, we're looking at, some of you already may know this, non-modifiable and modifiable risk factors. So, your patient is gender, male, although postmenopausal women now have equal rate to men in terms of heart disease. In this country, heart disease is the #1 killer for men and women. Okay, age. Okay, the older you are, the longer that heart's had to pump, and that alone can impact perfusion. Okay, another big one, family history. If you have a parent who has cardiac disease, there is a good chance you could have cardiac disease, okay, because you got the bad genes. Now, where in this country are we having an issue? Okay. Diet. Lack of physical activity. If you go back and look at some of the early shows, like when I was little, nobody was big. Everybody was like this. Aussie Harriet, you know, they were tiny. Dick Van Dyke, tiny. What's happened now? Okay. Also, smoking. Nicotine does what to the vessels? So, you should just see your preload and afterload going up. Preload, afterload going up. Okay. Hypertension. What do we love in this country? Oh, we love it. Okay. And diabetes. Majority of people with diabetes are type 2. Okay? So, there are others that we can now look at. But overall, these are some of the biggies that put you at risk for coronary artery disease. Okay, you remember you've got your RCA, and you've got your left main, your LAD, your little circs here, 1 and 2. So, if you have these risk factors or these, you know what happens? You start developing this stuff called plaque. Okay? It's called arteriosclerotic heart disease. So you get this plaque here. And you may be fine. This is called the silent killer. Okay? Like I said, that pump can pump. And you could go for years and years and years. Okay? And think you're fine. And as you go years and years and years, this just keeps building. And then, this one is called Elizabeth, I'm coming. Remember that? Sanford? Elizabeth, I'm coming. Oh, okay. This is your widowmaker. So, our goal as nurses is to educate, identify, and treat. And how many of you have really looked? Have you ever noticed the long, long list of cardiac meds? Long, long, long. Okay? Not to mention treatments. Okay? So, it's our responsibility to try and identify these people at risk and help them understand the importance of whether that be lifestyle change, compliance with medication because of this plaque formation. Okay? So, this is what your challenge is in the United States. And it's not just happening now, which is kind of sad, with adults. Kids are being tested, or at least mine are, for high cholesterol because of this problem in this country. Okay? And again, you want to identify early and treat. Why is that so important, guys? Once you have an infarction, that means necrosis to that muscle. You cannot change that. Okay? Once you have had a myocardial infarction, that tissue, that part of the heart is dead. And it doesn't move. So that's why it's so important to try and determine who's at risk and the importance of treatment. Okay, so as a nurse, this is kind of a good mnemonic, I guess is what you call it. But ask your patient to describe the pain. Okay? Describe the pain. You can always use the scale, but you want your patient to describe the pain that they're having. Or they may not be having pain. Did you know women and diabetics do not present with the old elephant crushing their chest? That is, your middle-aged adult male is the one who's usually presenting with the crushing elephant standing on the chest. But women and diabetics may have other types of symptoms, okay? You want to ask them the quality of that pain? Okay, is it sharp? Is it dull? Is it continuous? Is it intermittent? You also want to know if it radiates. It can radiate up the neck, down the arm is the classic theoretical picture that we have. You want to know if there's other signs and symptoms, such as shortness of breath, nausea, vomiting, diaphoretic. Do they have other symptoms? And above all, does anything that's treatment, does anything help it? Does it go away when you sit down? Or does it continue with rest? Did you take anything for it? Okay? So your patients can present with different signs and symptoms, but you never, ever take these symptoms for granted. Okay? Anybody that is in that at-risk category should be evaluated to rule out a cardiac problem. Then proceed with GI or whatever. Okay? But anybody at risk should be evaluated for a cardiac issue. Okay? It can be very difficult to identify signs and symptoms, again, in women and in diabetics. This is just one of those little cutesy things, kind of your assessment. That's very basic. Okay. So, after your assessment and your patient is at risk, your physician, or you may have standing orders to get more diagnostic tests. Okay? One that is now a gold standard is troponin TNI. That is a protein, guys, that is only released from a damaged myocardium. It is not released in a normal, healthy heart. You can even get this at the bedside now. A lot of EDs have the little tools to get a stat troponin. So it is released very quickly and it stays in the body. So it's a good indicator of myocardial damage. Okay? Another one is your creatine kinase. This is an enzyme. In particular, we're looking at the one that is showing the myocardial bands. Okay? This one is released quickly and stays in the body. Actually, to about day 3, it starts to trickle down. Oftentimes, you'll get orders for CKMB, Q8, times 3 for 48 hours or whatever. Okay, so those two are really, really big now. Your book talks about myoglobin. Guys, myoglobin can be released really with any type of inflammatory response. So we don't check myoglobin theoretically that much anymore. Okay, usually it's your troponins and your CKMBs. Okay?
How long does the troponin stay in the body?
Is it 24? No, it's longer than that. It's for quite some time. Now, the exact length, I don't remember. I'm sure I have it written down. No, it's more than that. It's released very quickly, and then it stays in the body for several days because it is an indicator of a damaged myocardium. It is not, you will not see that release, that protein release with a normal healthy heart. Okay? Now, your lipid profile. Okay. Does anybody in here get their cholesterol checked? Or do you all have plaque like this? You do?
No, I do too.
Mine was elevated.
Yours was elevated? Okay. Okay. I keep
My
laying
HDLs.
everything down.
What do you look at?
It's
on the table
by your book. Oh, thank you. Okay. Right by you.
Oh, I think you put the marker. Look behind the, over there, that table.
Oh, well, I'll use this. Okay. Now, just so, well, where's this stuff? Okay. This stuff, all right. So why did they keep them here? Orange. Did I lay it back there? Oh, I did. Sorry. Okay. Total cholesterol. Just for your nursing knowledge, you want less than 200. Total cholesterol. Okay. So if yours is above 200, you need to get what is referred to as a lipid profile. That breaks down your cholesterol into what is called your high-density lipoproteins, which is called your good cholesterol, and your low-density lipoproteins, which is called your bad cholesterol. Now, you want this greater than 60, and you want this less than 100. So when this is low and this is high, and let's say your total cholesterol is like 206, but this is low and this is high, you're in trouble. 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 Okay? To get a good HDL, exercise. Eating healthy and exercise is the best way to get a good HDL. Now, what is the medication that we give all the time? Statins. Your statins work great on this bad cholesterol. They work great to lower bad cholesterol.
Don't they also lower the good stuff? Don't they also lower your good?
Not if you exercise. Okay, and then your other one is your triglycerides. Your body makes. Okay, so you want this less than 150. So if your patient is at risk, but let's say they're not having any signs and symptoms, they still should have a lipid profile to see, that's a prevention measure, to see if they need to be put on a statin, okay, to lower that LDL. And hopefully it will make some lifestyle changes. Okay? Now these are for your symptoms, right? That we are going to identify a risk. They'll probably get an EKG too, an electrocardiogram, but this is going to be for your symptoms.
What are you doing to lower your triglycerides? Diet and exercise still?
Okay, got that? Now, another problem that we have in this country, it is costing health care in the billions, especially as we age and we have all those risk factors, is everybody in America has heart failure. Okay? And when the heart is got too much fluid volume, think of your patient, heart, bad heart, getting 150 milliliters per hour, this is going to rise. This is brain natriuretic peptide. It is a vasodilator that is released when the heart has too much volume. This BNP is what helps us, the physicians, to distinguish between, is this a bad case of pneumonia or is this truly a heart failure situation? This will be very, very elevated, okay, with heart failure. So BNP.
What does that stand for again?
Just want it like less than 100.
Oh, yeah.
Okay, BNP, brain natriuretic peptide, it is a vasodilator. It is released when the heart is in fluid overload, heart failure. It helps to distinguish between, is this a pneumonia case or is this more truly a heart failure case? If it's truly the heart, this will rise. I've seen this in the thousands. So,
You said it should be around, 100?
I think it's less than 100.
Less than 100.
And that's fine. You don't, I try not, you do need to know your lipid profile, but your BNP, I'm more concerned you know what it's for. More concerned with what it's for. Okay? This is more of a prevention thing, so I do like for my students to know, my nurses to know the lipid profile. Okay, other diagnostic, this is C-reactive protein is released when there's any type of major inflammation in the body. You can see C-reactive protein released. Not one, you may or may see it drawn. It depends on the physician. Homocysteine levels, that is an amino acid. They say high levels of homocysteine levels can contribute to cardiovascular disease. So they may check those levels. Let's see, chest x-ray, you guys know that. You can kind of look at the overall size of the heart. EKG, now that's your electrical conduction system, your electrocardiogram that's going to record that electrical conduction system that we talked about. If you're working in the hospital, I know all of you have probably seen EKGs, okay? Now, if you have a patient who's like having episodes of, let's say, syncope, you know what syncope is, okay? Then they may want, and based on their risk factors and everything, they may want to find out if they're having dysrhythmias. And one way they can do that is to put on what is called a Holter monitor. It actually will monitor them continuously, and the patient wears it for, 24, 48 hours, and keeps a diary. For example, if they have an episode of syncope, then they will write that down. And then once they go back to the physician, they will read that monitoring. So it's like a continuous EKG reading, almost, if you think of it that way. Another way to evaluate the heart is to actually see what it does with exercise. Okay? And that is called stress testing. Let's say your EKG showed something and the physician wants to evaluate further based on your genetic history. I don't know. So we can actually hook you up to leads and they will put you on a treadmill. And they monitor you, your symptoms, what your EKG reading is by inducing exercise. Now, of course, we have a lot of patients that do not have the capability of getting on a treadmill, right? So what do? You give them dye. We give them like dobutamine or persantine to help. Basically what that does is induce an exercise state without them having to get on a treadmill. Okay? Now I can tell you that if this is positive, your patient's probably going to buy this. Because that's going to indicate that there's probably some type of blockage. Okay? So with stress testing usually done before the gold standard of truly seeing what those coronary arteries look like, and that's cardiac catheterization. Okay? Now, with cardiac catheterization, it is your responsibility that they have sign of consent, of course, and that you document any allergies to iodine, shellfish. It is also, as a nurse, you need to be looking at their BUN, but in more concern, their creatinine level. Creatinine levels at 2.0 or greater are huge concern when you're giving that dye. Because how do you get rid of that dye? Kidneys. So that becomes a very problematic catch-22 if you need cardiac catheterization and you've got major renal issues. You know, do we hurt the kidneys or what are we going to do? And that's the cardiologist's call to make. Okay? With this, they're going to go in through the femoral. They can do a left and a right heart cath. And they will actually inject dye to see what is going on with those coronary vessels. Okay? It's very important. We have new equipment now that patients can actually get up or sit up in 2 to 6 hours. So it depends on who's doing it and what kind of facility you're in and what kind of equipment you have. Okay, so, but they need to be flat so that that artery in your groin does not bleed out, because that is a very big artery, the femoral. And it's very, very important to check pulses, okay, on that patient. So a lot of monitoring pre and post cardiac catheterization. Okay? A couple more I'm just going to mention. This one's the biggie I want you to be aware of. Right here. Because the majority of you are going to work in the hospital or you're going to send patients from the office for this to be done. Okay, echo is ultrasound. This echocardiogram, you can actually look at the valves in particular. They now have the ability to do what is called transesophageal echo. They actually put a scope down your esophagus and they can actually see what the valves are doing. Okay? cardiolite is like your hot spots. They inject this radioisotopes, and the hot spots will actually gather in the damaged part of the myocardium. Okay? One that is big now with prevention is your calcium scoring. That is done by CT, and they actually can give you a score as far as your potential for plaque formation, which I think is kind of cool. Someone last told me, does anybody know if insurance even covers this? I don't think it does, but it's not that expensive. But it's a good prevention tool. EPS is electrophysiology studies. That is where your patients are having major dysrhythmias, like life-threatening dysrhythmias. Can be life-threatening, I should say. You can have patients who have sustained life-threatening dysrhythmias, or they're having very high rates in heart rates. I've seen patients with rates of like 220 and up, okay? And what they do is that they actually take the patient in and actually cause the dysrhythmia to occur, and then what they'll do is ablate these accessory pathways that's causing this problem, okay? But that's EPS, if you see that. The big one, again, please make sure you're reading up on cardiac cath, okay? So a lot of diagnostics involved, as well as assessment findings, to just try and identify if this patient is going to need further treatment. Okay? Any questions about that? Let me look. So we went from chapter 35 to no, that's all in chapter 35, okay? Now, we're going to do this before we break. Okay, here's your patient of a rule-out myocardial infarction. What does myocardial infarction mean?
Heart attack.
Heart attack, okay? Dead tissue, dead muscle. So, what as a nurse would you like to know? Okay, you want labs. You want CKMB and troponin. What else? Okay, you want an EKG. What are you going to ask this patient? It's a PQRST. Okay, I want my nurses to think of PQRST, because this could help you to identify. Also, what else are you going to ask this patient about their history?
Their family history.
Their family history. You're going to look at their age, their gender, their modifiable risk factors.
Yeah, if they smoke.
In order to determine what is going on. Okay, so you've gotten your labs, you guys said. You can see we've got a risk factor, risk factor, risk factor. Risk factor. Postmenopausal women have equal heart disease rates as men. And she doesn't take anything. So she calls out to you, I'm having pain, chest pain.
PQRST.
Okay, you better get in that room, right? You do not think, oh, she's just whiny. She's just a whiny female. You know how they are. Okay? You better get in that room and you better start asking questions again that she is having pain. Okay? Now she's anxious, pale. What's happening to your... Okay, so your heart rate is actually low, but her skin is cool and dry. What's happening to that resistance? It's what? What's happening to the resistance? It's getting tighter. Okay? Her respiratories are labored. No edema. What are you going to do now? Is this a potential decreased cardiac output?
Yes.
Why?
Because she's dry.
What did we say we want this to be?
66.
Okay, decreased pulse, and she doesn't like it. Her body does not like it. What are you going to do, nurses? Okay, oxygen, right? Because when the heart's having to work harder, you've got increased myocardial O2 demand. Okay, oxygen would be good. You gonna stay with her? Yes. You better. Okay, you better. Stay with her and monitor. Get somebody to call the MD. MD wants the EKG. Oh, you should be relieved. What is this? What does it do? It dilates. So it's going to dilate those coronary arteries. And you're going to start a drip. Why this?
To thin the blood out. Allow it to pump.
What does it do?
Thin the blood out.
How does it thin blood? Decreases platelet aggregation. And do you think if you got plaque formation, those platelets are just... Yes. So we want aspirin to decrease platelet aggregation. Okay? I think you guys got this right. I told you that. Okay. Okay. While waiting, the physician determines she has had an MI. And so we're going to send her to the unit. We haven't talked about this much yet, but you guys know what thrombolytic therapy is. Clot busters. If you think of it as clot busters. Of course, she's going to be going to the cardiac cath probably eventually, but they're going to try and open up one of those arteries with a clot buster. So again, if your patient's receiving a clot buster has had a myocardial infarction, what are you going to do, nurses? Cry? Monitor. You think she needs to be on a monitor? Yes. Okay. What else? Watch for bleeding. What happens when you bleed?
Lose blood.
What happens? How do you know somebody is hypovolemic? Your first indicator is increased heart rate.
Increased heart rate.
Increased heart rate is the first indicator of a hypovolemic problem. And decreased BP. Okay? You going to take that oxygen off? Might not be wise. Okay? Might not be wise. She returns. How do you know she's better? What do you anticipate in someone who has now had their clot buster and now instead of clotting and plaque, we actually have blood flow to the myocardium. Vital signs normal, okay, or her normal. Perfusion. Skin warm and dry. Pulses. She's no cool, clammy. No complaints of pain. Perfusion has been restored. Everybody got yours?
It don't matter. It doesn't.
Okay. Did y'all get the diagnostics and everything? That's a little bit more straightforward, right? Okay. We can do one of two things. Now, this may actually help you. But again, we're going to go back and we're going to constantly reiterate what is happening to the heart from a physiology standpoint. Okay? So it makes sense to you. So go ahead and take 15 minutes. Information is coming from, hold on, chapter 40 in Iggy. Okay? You need to make an answer.
Yeah, just one before you guys leave today. If you need a computer for Kaplan testing tomorrow, I need to know about it before you leave today. Because I've got to reserve them before I fly in tomorrow morning and pick them up. Okay? So just stop by my office or shoot me an email.
What's tomorrow? Sight.
Yeah.
Go back to sight. Sit here and stuff your brains in cardiac. Go back to sight. Okay, so chapter 40. This is a huge problem in the United States because of modifiable risk factors. Okay? And there's a variety of reasons for that. Obviously, when you look at how our lifestyles have changed over the years, I think there's a variety of factors affecting that. Women in the workforce, no time to cook. You can find anything in the frozen section now. Not taking time, lack of sleep. Not enough time to exercise. There's just, again, a variety of factors that play into this. An aging population. So, again, it's called atherosclerotic plaque buildup. And it builds up in your coronaries. Okay? Those vessels that you have pictures of. And again, it can cause symptoms, or it may not, depending on how much plaque buildup you actually have. Okay? So, if you have a lot of plaque buildup in multiple vessels, then that's, going to affect your perfusion. And you're definitely probably going to have signs and symptoms from that. Okay? So, basically, as the plaque builds up, essentially, perfusion is decreased and myocardial oxygen demand is increased. Okay? And this all ties back to the previous part of class in what is actually really happening in the heart. And again, that vicious cycle will start if we do not identify early and treat. Okay? Now, also to let you know, these are some of the latest guidelines for the American Heart Association, which we are finding with evidence-based practice that if you have an increased waist circumference, men greater than 40 inches and women greater than 35 inches, then you could be at risk for cardiovascular disease. Okay? Also, high blood pressure. And notice, it's not that high. It's 120 to 130, over 80 to 89, or you're taking meds for high blood pressure. Okay? Also, mentioned this before, is your good cholesterol low? Low is deemed less than 40 in men, less than 50 in women, or you're taking meds such as your statins. Are your triglycerides high, or you're taking meds, okay? If you have 3 of these, then you have what is called, a fasting blood glucose greater than 100, or you take meds for your high sugar, then this is called metabolic syndrome or syndrome X. You probably talked about it with diabetes. If not, I don't know why, but metabolic syndrome. And this, of course, is another evidence-based practice guidelines that we now look at to identify if you are at risk for coronary artery disease. Okay? So those are just some of the things that we're seeing now. So as you start to try and visualize, instead of this nice blood flow going through these vessels to supply the right and left side of the heart, we now have this plaque formation in these vessels. Okay? So depending on how much plaque formation will determine if you have symptoms. So why is this a problem? Well, lack of blood flow, as I mentioned before, to the body and to the myocardium can result in what we call ischemia. And that means that area of the myocardium is lacking blood flow and oxygen. And that's a problem. Why? If that cycle continues, decreased blood flow, increased myocardial demands not being met, then you can have a heart attack or actual death of part of the myocardium. Okay? And eventually you'll learn, like, we divide the heart up into different terms. For example, if you have damage on the right side of the heart, that's called an inferior wall MI. Damage to the left side of the heart is an anterior wall MI. Both of them can be very problematic for your patient in that this is irreversible. Okay? So that's why it's so important to treat, identify early, and treat. Okay? Now, again, the myocardium will keep pumping, but as I mentioned, those ventricles will enlarge. The myocardium, the vessels, you can even have a situation where say the left side of the heart is damaged. Okay, so let's say the left side of the heart is damaged. You can even have a situation where the right side tries to feed blood flow into it. And that is called collaterals. That is the heart trying to compensate for that lack of blood flow. You know, actually try to feed with vessels. And that's called collateral circulation. May help, may not, depending on the extent of the damage. Okay? Oh, sorry, wrong way. So, if you're having decreased blood flow, decreased oxygen, increased O2 demand, you can have what is called angina. Or a lot of people in the South will say angina, angina. And that is referred to as chest pain. Now, nurses are very alert, most of all of us are very alert to chest pain, but as you're learning in class, not everybody presents with the elephant on their chest presentation. So that's why you're looking at history and your physical exam and your questions that you ask them and your lab values become very, very critical. Okay? This is how you'll see it labeled in the chart. Stable angina means that it is relieved with rest. It occurs with exertion. Okay, so your patient may have stable angina as they're walking on that treadmill. The exertion is what is leading to the decreased perfusion and the decreased oxygen to the myocardium. And oftentimes, rest can stop that pain because the heart is not working as hard, or they may be a patient who takes a nitroglycerin, and that's enough to cause vasodilation and relieve that pain. Where do we get concerned? It's called USA, unstable angina. This is a patient whose pain is truly, the intensity is more severe, it's continuous, it does not go away with rest, and you certainly can see other signs and symptoms such as radiation. This person needs help. Okay, this person is in need of help. Okay? If you do not know of anything else to do, you need to get a monitor on this patient, and you need to get some oxygen on this patient to try and relieve some of that demand for oxygen. Okay? So again, this is our concern. This is a concern. But we have a lot of cardiac patients, guys, that they know that if they increase their activity, if today I decide I'm going to go out and mow the whole dang yard, well, they'll probably sit down, pop a nitroglycerin or two, and then get up and go on their merry way. Now, the problem is, this person can become this person. Especially if they're not taking care of themselves or they're not on the proper medication. Okay? Because, again, we have patients that have had myocardial infarction times 2. You know? So, they live. Because the heart's going to keep working. But with medication and some changes in their lifestyle, they can live very productive lives, taking their meds. The problem recurs, again, when that pain does not stop. And like I said, you can have other signs and symptoms. Again, be very, very, what do I want to say? You know, really get to the problem here with these people, because they may not present with that characteristic, you know, oh, Elizabeth, I'm coming, you know, radiating down the arm and all that stuff. I've had females who had a toothache, felt like a toothache that just wouldn't go away. You know, back pain. So again, you as a nurse are at the bedside. I probably have several students in here that are going to be my ED nurses. Okay? You need to know how to assess these people and not take that pain for granted. Like I said, these patients should be ruled out cardiac first. Then you can progress to other things. Because time is muscle, essentially. So be very aware. I've just listed a lot of these out. Feeling tired, you know, that could be a clue that something is truly going on from a cardiac standpoint. This is one of those cute little pictures. Just, it may help some of you with the symptoms. But as I mentioned, not every patient, in fact, not a lot at all, present with that characteristic crushing mid-sternal chest pain. But a lot of them will. So, as a nurse, it is up to you to identify that cardiac output is impaired. Okay? And knowing what to look for at risk, how to assess, and things that you can do first. Okay? A lot of times I have taught my students a good thing to think about, just because students seem to like mnemonics really well, with unstable angina, okay? If you'll think of MONA, and it's not in that order, but oxygen, aspirin, nitroglycerin, and morphine. MONA. Again, it is not in that order, but it's just a mnemonic that helps students to try and think when you are in the real world in that situation of what I need to do. Okay? And of course, it's a given, you get them on a monitor. Okay? But, so oxygen, aspirin, maybe you're at home. You know, those are two things that you could help your neighbor or family member with. Is certainly give them an aspirin. If they have nitroglycerin, they can take one nitroglycerin. How often? Every 3 to 5 minutes times 3. Okay? If it is not relieved, you need to call 911. Okay? Because that person needs oxygen, nitroglycerin, and probably some morphine to help with the pain. Morphine's going to cause vasodilation as well, and those are the things for the immediate need of this patient, because time is muscle. A lot of teaching involved based on what we've talked about earlier. And of course, we're going to be getting into the almighty cardiac meds. There's a lot of them. Y'all are going to hate me by the end of this week. Tomorrow I'm teaching that drip calculation. Oh, Lord. Of course, you know I have to throw my meds in there, too, because that's just me. So, a lot of the things I have already told you. There's the MONA. I did put it on your slide. So, again, just always remember it's not in this order. You have to think about that patient and what you can do initially. There can be a lot of anxiety, just like with a patient who can't get their breath. You know, someone having chest pain is very alarming, okay? I've had students who had chest pain, and most of them were diagnosed with hypertension. You know, it's very, very frightening to have pain in your chest. Okay, so very briefly here, I want to look at, let's get you a good foundation. An O-law. That's what I do with my seniors. What's an O-law? What's an O-law? What's it doing? Okay. And as a beta blocker, you need to know that you didn't know before, you have cardioselective and non-cardioselective. Most of the old beta blockers are non-cardioselective, meaning that they block beta 1 and beta 2. Okay, beta 1 stimulates the heart, beta 2 causes vasodilation. So why do we like cardioselective beta blockers? Because oftentimes our cardiac patients have dang COPD and pulmonary issues. So we don't want to block this and cause vasoconstriction. So cardioselective beta blockers target the one that increases the heart rate. That's like your Toprol, your low pressors. There's others listed in your book. See, I can remember when those did not exist. What did we take? What did I give patients? Indorol. Indorol. You know, we just didn't have a lot of selection. So now we have cardioselective, which is great for your patients that have strong pulmonary issues to not cause more problems with that. Okay? So your beta blockers, again, why? What is the meaning? You got to rise from first year. So you're decreasing heart rate, right, in this diseased myocardium. Why is that important? Okay, so if a diseased myocardium is pumping at 110 beats a minute, is blood flow going out? No. I mean, we got a problem as it is. And at 110 beats a minute, that blood's going out, it's pumping fast, 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 and then what happens? It doesn't have time to fill, right? It doesn't have time to repolarize. And that's a vicious, vicious cycle. You cannot let a diseased myocardium heart rate get too high. It works the heart, increases myocardial demand, and we can't have that, okay? So by blocking the beta, we're going to lower heart rate, and that's going to enhance filling time in the ventricles, and that's going to enhance stroke volume. Thus, perfusion is now improved, right? Beta blockers, again, are gold standard in diseased myocardiums, myocardial infarction. They do have side effects, decrease. You can knock that heart rate down. So that's why you look at trends. You can knock that blood pressure down. That's why you look at trends. I will tell you, most cardiac patients, a good rule of thumb is heart rate less than 55, I would use caution. A heart rate less than 95, I would use caution. And again, if you're seeing a trend downward, you need to be using caution and questioning. Okay? So, you don't use beta blockers. I won't go there. I forgot y'all. Okay. So those are the ways that it protects the myocardium. Okay? Think of that. Cardiac output equals heart rate times stroke volume. By lowering heart rate, I'm increasing the filling time in the ventricles, and that enhances my stroke volume. And perfusion is improved. Okay? Got it? I need to really read, Miss Homer. Okay, another one, very, very important to the function of the heart for normal contractility is calcium. But again, when your heart rate is too high and that resistance is tight, then we can actually block the calcium influx. By blocking that calcium influx, I decrease heart rate and I help dilate my systemic vessels. And that's going to in turn help perfusion. Help perfusion. Okay? I know y'all are like, okay, you're there, guys. I hate to say it. But you're there now. This is second year. It's not easy anymore. Okay? So, blocking that influx of calcium, which I showed you on this. Those are required for normal contraction, preferably at 60 to 100. By blocking that calcium, I'm going to decrease my heart rate, which increases filling time, and I'm going to help my tight resistance to dilate. And therefore, we'll get more blood out, more blood coming back to that diseased heart. These are mnemonics, very nice drugs. Verapamil, nifedipine, diltiazem. This is your biggie now, is diltiazem. It can be given in an IV drip. Again, be very careful with bradycardic rhythms, blood pressures less than 95 systolic. Okay, you got to use caution. Okay, ACE inhibitors and angiotensin reverse blockers. ACE inhibitors are called your prils. Okay? Why are prils so important? Do you remember what I said about decreased perfusion to the kidney? Decreased perfusion to the kidney means release of renin, angiotensin II, and aldosterone. So we can now prevent the conversion of angiotensin 1 to 2 with an ACE inhibitor. And by doing that, you prevent that potent vasoconstriction and retention of aldosterone. That's why these have become a gold standard in diabetic patients. Okay? It's going to prevent that conversion of angiotensin 1 to 2, your potent vasoconstrictor. Okay? Now, also, a lot of times what we do is give this in combination with a diuretic. Okay? Because you're going to have that fluid retention. So we often give a pril with like a thiazide diuretic. And it can work beautifully. Okay? Your angiotensin reverse blockers work directly at angiotensin II. So it prevents that major vasoconstriction. Why do we use those? Okay, one, ARBs are more costly. And usually the only time we see the use of ARBs is when the patient doesn't respond to an ACE inhibitor or has side effects from that ACE inhibitor. Okay, one side effect is ACE inhibitors cause the release of bradykinin, which can cause that nasty and they don't like it, that dry cough. So if that's the case, then we'll go to the ARBs, okay, to have a similar effect on this patient. Okay, we'll finish up with meds here. Diuretics. Thiazide diuretics, loop diuretics. Which works faster? Loop works faster. Can be given by themselves or in combination, oftentimes with your prils. Your loop diuretics, such as Lasix, can be given IV push and as a drip. They work very, very quickly to get rid of fluid. You also are going to lose sodium and potassium. So knowing now some of your critical ions, you have to be very careful of watching those potassium levels, because 95% of your potassium is lost in your urine. So you got a diseased myocardium, you have to give the diuretics, but you're losing the potassium, you better stay on top of it. Because if that potassium gets too low, that heart is not going to contract properly. In fact, you're going to have dysrhythmias. Okay? And that can cause another problem in perfusion. So your diuretics are very, very important. We do have one that's good. We use it a lot with our patients that have congestive heart failure, and that is our potassium-sparing diuretics, like aldactone or spirulactone. Okay, they're great in that they can actually lose fluid but not lose the potassium. Potassium-sparing diuretics. Okay, we see that a lot with our heart failure patients. And what we'll do, oftentimes I like to revisit with material that's complex, because that's where you guys are at now. So we'll revisit some of this, in particular the meds, before we move on to the other disease processes that we talk about. This is vasodilator. It's an old drug. It works great. Okay, this can be given in a drip as well as sublingual. Okay, but it's a potent vasodilator to those coronary vessels. So it works great in enhancing perfusion, but you are going to need to watch your blood pressure. Okay, but great vasodilator. Talked about aspirin. This inhibits platelet aggregation. And then, of course, we have, these are big now, your platelet inhibitors, such as Plavix, because with plaque formation in the vessels, you're going to have increased platelets congregating at that vessel and making a situation, just making everything worse as far as plaque formation, okay? So those are a ton, some of the meds. That's the beginning of cardiac. Again, next week we'll revisit some of this. My seniors last year told me that was very helpful because it's a lot of material and it's complex. So we'll revisit and then we'll move to the big one that you've got to understand, which I'm hoping you will, is heart failure. Okay? So guys,